Hello and welcome back to another episode of the Pharmacist Diaries podcast. This week I am bringing you an amazing podcast series for World Antimicrobial Resistance Awareness Week. We have already seen multiple episodes of pharmacists and a patient story, but today I'm actually going to be able to share with you what do antimicrobial pharmacists even do. We are going to learn from Neha Voralia. She is currently working at Buckinghamshire NHS Trust with me and Claire, and she is an advanced anti-infectives pharmacist. But our paths crossed back at Great Ormond Street Hospital only a few months ago when I was locuming there. So I got exposure to the fact that she worked at a paediatric hospital in infectious diseases, but now we are both entering the adult world together. So let's introduce Neha to the podcast. Hello.
Hi, Anisha. Thanks for having me.
Absolutely. Looking forward to our little convo. Let's take you back quite a few years to student life and why you decided to become a pharmacist in the first place.
To be honest, I think it wasn't one of those automatic things where I was like, pharmacy is definitely the one. I always was just naturally good at sort of science and maths, and sort of English wasn't really a subject for me. So I knew I wanted to do something scientific. And then I think just looking into it and job prospects, I thought pharmacy would be a good career. And I knew I definitely didn't want to do medicine. So that was out for me. I didn't want to be a doctor. And I thought with like nursing and all the other professions, I didn't really want that hands-on patient contact and sort of like touching people. So I thought pharmacy would be quite a good option. So that's why I thought I would go for pharmacy in the end.
Awesome. And as a student studying pharmacy, what were your initial thoughts about what you liked about the career options that were available to you? And what were towards the end of the degree, what were your thoughts as to where you would go in terms of your career?
So that's actually quite interesting. When I first started pharmacy, I had no idea about how broad it could be. So all I really knew about pharmacy was, I guess, your traditional community pharmacy role, and that's where you see pharmacists a lot. And I'd heard about sort of pharmacists working in hospital, but again, not really sure exactly what they do. But even just the opportunity of that you can work in industry or sort of in the army or even academic, like I had no idea you could go into these kind of things. So it did kind of broaden it for me to decide what I wanted to do. And also throughout my sort of university years, I worked in Boots just as a student on a Saturday, a weekend job in the pharmacy. So I had a lot of experience in community and it was great. But I think because I spent so much time there, it kind of showed me that I didn't want to pursue community and I didn't want sort of that business orientated role. And I actually met a really good locum. It was one of our locums I met at Boots and he was a paediatric hospital pharmacist. So just by speaking to him, I was just like, wow, like he has a really interesting job and I think it's like something I'd like to try. So I thought hospital was the one for me when I finished university.
Awesome. I mean, we're so lucky now that Pharmacist Diaries exists. I mean, shout out to myself right now because university students have so much more information available to them compared to when we were studying. We had the traditional careers fairs. We were put onto placements, but back then, even when I was a student, and this is 2005 to 2009, I only had placements that were hospital were 2 days and community pharmacy would be 1 or 2 weeks. But like you, I worked in community throughout my university degree. My parents owned pharmacies, though they're not pharmacists. They were owners of pharmacies when I was growing up, so I spent a lot of time in community pharmacy. And I did really enjoy it. I love the relationship building aspect, regular customers coming through, getting to know people. I mean, it's just part of who I am and what I like in terms of my personality. But there was something that felt a little bit missing with retail pharmacy that I wanted to explore other options. And because I had so much exposure to community, I was like, yeah, I want to try something else, especially for my training year. So I definitely applied for a pre-reg program in hospital so I could immerse myself in that environment and truly understand like what my next steps would be come qualification. It sounds like we had quite a similar journey from that perspective. What was your training year like? What did you get exposed to during that time, which helped you to navigate your next steps?
So actually, I didn't do my pre-reg in a hospital. It was when I was applying for pre-regs, that was when GP and primary care was first coming up and about, and it was talks about pharmacists kind of going into primary care and working in GPs. So I did my pre-reg at an independent pharmacy, but it was connected to a GP practice. So it was kind of split between working with that practice and then also in the community pharmacy. So it was the first year that I think pre-registration students were kind of in that setting. So it wasn't as structured, I think, as it is now, because it was such a new role. And I think we were still defining what the role of a pharmacist in sort of primary care in a GP practice is. But it kind of gave you that more clinical element. So I completely agree with you in sense of community. I really enjoyed working in the independent because you really get to know your patients, and you see them every month coming to pick their prescriptions up, or if they're just coming in for minor ailments, and you build relationships with them and really get to know them. So I really enjoyed that aspect, but having that GP side of it and seeing that additional clinical part, I just felt that's something more I want to explore, and it's missing from community. And there was more I could do and utilize all of these skills that you've learned from 4 years of uni. I thought there's more to it, and I wanted to explore the more clinical side of pharmacy.
What year was that?
So I did my pre-reg starting in 2018, and then I qualified in 2019.
Awesome. So going into a GP practice as a training pharmacist or a pre-reg pharmacist, did you find it was quite simple to be able to achieve the standards that were required for your training year compared to a retail pharmacy? And the only reason why I bring this up is we always have lots of younger students or trainee pharmacists who listen to this episode. And what was it about working in a GP practice that allowed you to explore different skills and standards that are expected upon qualification? What was your experience like from that point of view?
So we were really lucky that the practice that we were connected to, they already had a pharmacist working there. So he was quite established. And I had another student with me who was doing pre-reg as well. So there was two of us. And it would just be simple tasks. So say if something was out of stock in community and they send the prescriptions back to the GP for an alternative, they would automatically go to the pharmacist. And he would then give us these prescriptions and just say, have a go, look at the guidelines and see what you think and if you can come up with any alternatives. And just sort of going through that process, I think it really helped us in terms of not only looking for resources, so where to find information, it helped us sort of achieve those outcomes. And also sort of looking at first line, second line, and looking more into sort of bloods and patient history and seeing what's appropriate, what's not appropriate in terms of what we would give as alternatives, what's available. Whereas I think if we were just in community, you send those scripts back and then that's the end of it. You don't see them until they come back, and then you have alternative, and then you clinically screen that, and then you would dispense that. And we also had the opportunity to sort of sit in with the GPs and see how they do consultations as well. So we had really early exposure to how sort of patient consultation is done, how a detailed history taking is done in terms of not just your traditional drug history, but looking at sort of their symptoms, red flags, social history, and seeing a holistic picture of how a diagnosis is made.
It's so hard to do in the 7 minutes that you get. I think that's one of the biggest challenges that I think that GP practice pharmacists and GPs have to take into consideration, 7 to 10 minute window to do a full medical history, physical exam, ask lots of questions, come up with the diagnosis, order your tests, write your notes, and explain all of that to the patient. I think it's an incredibly challenging environment to be in, but one where you can build really different skills to what you do in a hospital setting. I love the hospital setting. For me, if I want to spend half an hour with a patient, it's about understanding how I can manage my own time to be able to give that patient what they need, or the high-risk patients or the patients that genuinely need a lot of education, or they have complex medication regimes, or they're starting on warfarin where you need to give more counselling or methotrexate or something. And you can manage your time effectively to spend more time with them and then speed up your regime to review lots of other patients, especially when electronic prescribing has come into place. It's making things a lot easier for us as well to be able to clinically review patients. But I think a GP setting can be quite challenging because you're just back to back all day. And and you've got that limited time frame. But you also have access to a lot more information than you do in a community pharmacy. And being able to understand what the role of a pharmacist is like in all three settings is also so valuable. And having the opportunity to also work in those three settings in your journey is so valuable when you're in the foundation stages, because you understand what the communication streams are like, what important information is there when you're transferring from a hospital to a GP practice and community in terms of changes on discharge or implementing new medications, or like you said, you got exposed to formulary where maybe something is a hospital only drug and now it's no longer available, thinking about alternatives, thinking about the cost, thinking about the effectiveness and looking up evidence and guidelines. And that's so valuable in the early stages of a training year. So what a great opportunity. And then from your training year, how did you end up in a hospital setting?
So after sort of completing pre-reg, although I really enjoyed it, and I enjoyed independent pharmacy much more than sort of a retail, a busy environment, I still was missing that clinical element, and it's something I wanted to pursue more. And although GP was great, because it was still new, I think the roles weren't established yet, and it was really unclear where that would lead. So I thought hospital is something I haven't really tried yet. So although, like you said, I had placements in uni, but they were often really only a day or two. And it's really limited what you can gain from that. So your time is split between meeting all these different people or spending an hour with different pharmacists in different roles. It's really difficult to kind of really understand what you do. So it's something I wanted to try, and one sector being that I hadn't worked in yet. So I applied for a couple of band sixes, and in the end I went for Northampton General, which is where I started my band six. And I did all the traditional rotations there. But I was really lucky in the sense that with Northampton, they have a really big vascular centre. So a lot of vascular patients come in, and you end up seeing a lot of diabetic foot patients. So a lot of people are really squeamish about this, but I was really drawn to it, and it was so interesting. And this is where I really had an introduction to complex antibiotics and complex antibiotic regimes, and even larvae therapy, which some people were like, oh my God, larvae. But even that was just so cool to me, to be like, oh my God, like essentially we're putting maggots on someone and it's going to eat all the dead tissue, and like hopefully their foot is going to be okay. So I really enjoyed sort of the surgical aspect of it, and I ended up covering sort of every single surgical rotation I could go on, and even respiratory as well. But it was the antibiotics that I was really drawn to. So I did a year of rotations, and then unfortunately 2020, then COVID hit. So it just became about sort of working in the pandemic, being in that acute setting, ending up on admissions. And unfortunately, a lot of our team did get really unwell from COVID. So then I was off for a long period of time. And then just coincidentally, a band 7 job came up, and it was split antimicrobials and split clinical. And I wasn't sure if I wanted to specialise at this point, because I quite enjoyed rotating to different areas. I thought if I spent too long in one area, I'd feel like I need a change. And I get quite sort of bored with it, and I needed to see something new. But I thought with antimicrobials, I found sort of the complex regimes really interesting. And I thought, you know what, I'm still going to have that clinical aspect. So I'm still able to rotate, and I'll be able to learn a new skill as well. And I had a bit of interest already in infectious diseases. So going back to uni, my dissertation was very pharmaceutics based, but it essentially was just looking at a new formulation that could potentially be used for PrEP, so HIV PrEP. And through that, I had to do a lot of background reading about what HIV is, what the current treatments are. So I already had a little bit of interest sort of in the infectious diseases sector. And I thought, why not? Let's just go for it. And I started the role there, and I've not looked back since. I fell in love with antimicrobials and ID. So although I'm very new in my AMS career, it's, I think, definitely the one for me. Like, I've found my passion in pharmacy 100%.
Woohoo! I love hearing that, because it's always nice to hear when people are super passionate or find something that they're like, yes, this is it. I'm in love. I'm doing it. I found that when I stepped into paediatrics, which I found here at Stoke Mandeville Hospital covering the NICU. I did like it as a band 6, did my rotation, but I was a little bit fearful because we were using paper charts then, and then all the doses were weird and wonderful. And Oxford also has, where I was working, has really complex conditions. And there was a cancer ward. It was quite scary. So, and then covering the NICU, it's a massive, 50 plus bed unit. And I found it quite intimidating. But I also at that point felt like I needed to explore adult care and get my foundations before I start deciding on a specialist area. I mean, I didn't know I was going to move abroad and fall in love and follow my husband. But when I did come back to the UK, I wasn't expecting to find paediatrics, but covering the neonatal unit helped me to discover my love for it. I think also becoming a parent helped me with that journey as well, because I just really liked the relationship that I was building with mums most of the time, the conversations we were having, as well as being able to help the patient as well. And that's something that really resonates with me as a pharmacist. Like that contact with the patient, having conversations, building that relationship is so valuable to my joy when it comes to being a pharmacist. So it's really nice to see that you found your passion quite early in your journey as well. So when you stepped up from a band 6 to a band 7 and you went into this antimicrobial role, what was your kind of day in the life like? What was the actual role like? Because you've done multiple sort of antimicrobial jobs. You've been in adults, you obviously moved to paediatrics, you're now with us. But what was the initial journey like for you in terms of the role?
So it was actually quite challenging with stepping up into that role with antimicrobials. It's a very hands-on role. And it's very MDT working. So we were constantly sort of in discussions with our microbiologist, working with IPC, and also just your general pharmacy team. Everyone almost looks at you if they have any queries or discussing patients. And even our microbiologist, when we used to go on rounds, he would ask for your opinion based on what cultures and sensitivities were. So obviously being very new to the role, hearing all the bacteria names and everyone's sort of like gram-positive, gram-negative, this covers this covers this, and you're trying to wrap your head around what's covering what, and you're trying to keep up with the round. It definitely was a challenge sort of stepping into it. And I think I didn't realise just how broad the role was. So although like traditionally you just think of AMS, they look at antibiotics, they go on ward rounds, but there was so much more to being an antimicrobial pharmacist in terms of there was a whole governance aspect of the role, sort of you're responsible for guidelines, reviewing them, policies, infection prevention, that's a whole nother role, working with IPC, reviewing your hospital-acquired infections. If you had any bacteremias or any C. diffs, we would then go back and do a root cause analysis to see if there was any contributing factors, your day-to-day clinical queries. And we also had multiple clinics ongoing that we could get involved with. So as I mentioned before, because we were a vascular centre, we had a diabetic foot round you could join onto. We had hepatitis nurses you could join onto their clinics. And actually, we had a really big chest clinic. And I found out later on that we used to have a weekly TB clinic. And that really sparked my interest because I was like, oh God, there's so many patients that have TB or query TB that we're running a weekly clinic. So I got involved with that quite early on because it really stood out to me. And I was like, oh, wow, this is like really interesting. But then once you sort of found your feet a little bit, I guess it was sort of going on the rounds, your day-to-day activities. And I was really lucky that our lead was very supportive. And our team was quite big as well. So it was not only our lead, but we had 2 band 7s working within antimicrobials. And we were quite closely linked with our neighbouring hospital, Kettering, and we worked closely with their team when we had a patient who was sort of transferring particularly any diabetic foot patients. And at the time, I'm not sure if you're familiar with him, Ryan Hamilton, so great AMS pharmacist. He used to work at Kettering, and he's so enthusiastic, so passionate. Any sort of like diabetic foot patients that were cross-cover, we would be emailing about them and sort of having that collaborative working. So I think that's the part I really liked about it. And I was exposed to so many more MDT members. Rather than your traditional ward working, you almost review your patients, you discuss them with your doctors and you have your nurses. But just the different members of staff you're exposed to working within AMS. And also regionally as well. you get involved with working within your region, working with your primary care networks to see what's going on locally in terms of resistance and seeing what everyone else is working with. And of course, Well Week, it's always a bit of fun, depending on what's going on, what activities you plan. So I just really jumped in heads on into the role, and also having that clinical aspect as well, because it was a split role. So I think learning how to split your time between my AMS commitments and also my surgical commitments as well.
Man, that's a lot of information, but great information. I'm so happy that you brought all of that up. And when you consider what you're like as a Band 6 pharmacist, you generally are allocated to a specific ward area. You might have some dispensary slots. But when you step into this type of role as a Band 7, it's quite a big jump. It's quite a significant change to your routine. You're involved with so many different things, from guidelines, research, looking at different resistance patterns, data collection. You are working with lots of different healthcare professionals, and you're using quite a few different skills as well. But one of the things that really excites me about being an antimicrobial pharmacist is that your knowledge and the information that's kind of held within your brain is just intense.
Yeah.
Like, you've got to know a lot of stuff. You've got to know, and you've got to know not just about the bacteria and which drugs would target that bacteria, but you've got to take in the patient as well into consideration, as you do with any drug. But your mind is kind of on overload. And when I attend ICU ward rounds, even here, you're thinking about those things. You're linking with what the sensitivities are. You're listening to the microbiologist. You are looking at renal function. You're thinking about levels. You're thinking about the IV to oral switches. I mean, if you compare it to post-op surgery and looking at pain, you follow the World Health Organization pain ladder. Of course, there's lots of things from pharmacokinetics and everything that you take into consideration, but your brain is not necessarily buzzing the whole time when you think about paracetamol, some codeine, maybe some ibuprofen, and even low doses of morphine. I feel like the nature of antimicrobials is just complex to the point where you are really utilizing a lot of that skill, and you are an expert, and you are seen in a different light, I think, compared to other specialist areas that I've had exposure to. Now, I'm not trying to insult any other specialist areas. This is all about antimicrobials, and we're boosting what antimicrobial pharmacists do. But it is really interesting how my brain ticks in this role in comparison to other things that I've done. I'd really like to explore with you what your thoughts are on when you moved over to Great Ormond Street Hospital, and you're obviously working with paediatrics. How was it different doing that role compared to adults? Like, are there specific differences that you noticed that helped you with your kind of learning journey, like your professional development? What are your thoughts on that?
So moving to GOSH, that was a big change for me. So I was actually really nervous going into the role, because although in rotations I'd covered general paediatrics, so I had an idea about what peds was, and I'd done a rotation, I don't think I fully grasped how different a tertiary centre would be compared to district general. So in terms of AMS, I was quite at that point comfortable with AMS, and I'd been in sort of the job for a couple of years and found my feet a little bit. So I guess the general principles of AMS remain the same, but almost with the tertiary centre, it was by the time a patient is transferred to you, they would have already been through their GP, their local hospital, they would have had their first line and even sometimes their second or third line, and then they're transferred over to a specialist centre like GOSH, and then you're almost responsible for this patient, and it's like, where do you go from there? The guidelines only cover you so far, and then they've already had X amount of antimicrobials, they're incredibly sick, there's no information available, and they're colonized with so many resistant organisms, and you're the point of call for that. So although it is very much MDT working, the decision making was a massive step up, and also transitioning fully to peds as well. It was different doses, in terms of drug monitoring as well. In terms of adults, although there is sort of TDM, so like your things like your vancomycin, gentamicin, your monitoring levels. With peds, it's not one fits all. So you're dosing for a neonate could be very different to, say, a 5-year-old, and that could be very different to a teenager. So you almost have multiple sets of doses you need to be responsible for, different levels, different pharmacokinetics, and it was just such a challenge. And especially because of it being sort of such a renowned centre, we had international patients coming over, and they presented a whole new challenge in themselves, where maybe the organisms and sort of the bugs that they're colonised with and their resistant patterns are completely different to kids that are maybe in the UK, transferred from different areas. So just sort of the plan that you need to make. And also generally being peds, of course they're only kids and they're really unwell. So trying to get them to take medications. And often with sort of your first line, second line medications, there's not a lot of information available in terms of paediatric doses. There's limited clinical trials happening. So when you're sort of moving into unlicensed territory, not only you're looking at using an unlicensed medication where there's very limited usage in adults, limited information, you then need to use this information to dose almost premature neonates. So it was incredibly challenging and very different in terms of stewardship. And I think there was also a lot more exposure to infectious diseases at Great Ormond Street as well, because we had various clinics running alongside. So not only I was covering stewardship and your traditional microbiology that you might see in an AMS role, but we had Hep C clinics, TB clinics, HIV clinics. And often the patients that you might see in those kind of clinics, so say, for example, TB clinics, you get to see sort of your MDR TB, XDR TB, so a lot of drug resistance. So it's not your traditional, and then that poses a challenge in itself as well. You end up with these complex regimes. So say for TB in an adult with MDR TB, they're often on really complex regimes of 5 to 6 drugs. You then have that challenge of trying to get a child to take 5 to 6 different medications. Can they even swallow these medications? Can these medications be crushed? Is there anything we can do? And they're often very long courses. So to get a child to be compliant for almost 9, 12, 18 months, however much their course is going to last, that's a different challenge in itself. And then if you have a gap in treatment, you have to restart. Explaining to the child as well, depending on the age, why are they taking these medications? And that poses a risk in itself. If you've then got a child with XDR TB or MDR TB not taking medications, we have to then withdraw them from school. They can't sort of be running around due to public health risk. It's sort of developmental as well, because how long can you pull them out of school for? And there's a lot of the side of it that you have to think about in peds that traditionally you wouldn't consider when treating adults.
When you get exposed to peds, it's next level.
Yeah.
There's nothing else I can say except it's next level. Your brain is just on overload in the most exciting of ways.
Mm-hmm.
I've just fallen in love with it because you live in the grey. You're just constantly problem solving and figuring things out. And it is so individual to every single patient that you see. And I also love working with a neonate. I mean, covering a general peds ward at the Evelina, you know, within one bay, you've got a newborn baby next to a 17-year-old, and then you've got a little 5-year-old, and then the 2-year-old who barely talks. So the conversations that you have, even within that 4-bedded bay, is just wildly different. Dosing is wildly different. Getting them to adhere to medications and be able to either swallow whole capsules versus trying to get the liquids, or crushing tablets and figuring out solutions as to how to hide it in food or milk or, you know, yogurt or whatever it is that you're trying to do. It's just a lot of fun because you're constantly working really, really hard as a pharmacist to do what's right for that individual. It's so hard to just screen a drug chart and walk away, because the involvement that you have with the parents to get on board, or the carers as well, is you have such a big impact. I would never really screen remotely at the Evelina when I work there. I love just being on my laptop or having those, you know, movable computers, the cows, and just go bed by bed and just see family members, talk to them, get them to tell me a lot more about the medications. What surprises me about children, especially when you talk about complex regimes, is how much they know. Because with renal transplant patients, we had like 3 to 4-year-olds who understand so much about their medicines, the names, like interactions, like I need blood levels for this drug. And it's just their resiliency. It's just inspiring to be around kids like that. And it makes you realize, like, again, it gives you a lot of gratitude because thankfully I've got a family who are well, and you see all of these really challenging situations, especially in palliative care. But the impact of the pharmacist is amazing. And I can imagine that it was a real step up for you. And I believe you were a team of 1.
Yeah. So team of 1 covering antimicrobial stewardship, infectious diseases, and paediatric HIV.
Yeah, that's a lot, but amazing because you can see how your career has shifted, in quite a short space of time. Go you. I love this. I told you this episode was going to be great because you get to share and reflect on your journey, and you can see how far you've come. And now you're obviously working in the best place with Claire and, Team Bucks. And it's gonna shift your career trajectory in a different format. And I love that. I guess, from the perspective of the future, which I like to go into the future because I like people to look ahead and kind of see where they're going or what they want to achieve. What's kind of missing from your career at the moment that you'd really like to do? Or what are the gaps in your practice that you're like, oh, I really want to get involved with that and take my career to the next level?
So I think, so as I said, I'm still very much early on in my AMS journey in comparison to Claire. Claire's just like
legend.
Next level. Yeah. Like no comparison. Oh my God. But I think expanding maybe more of the ID side of it. So although I have some experience in paediatric HIV, I think exploring the adult side of it. And I'm really lucky that with Kate being here, I've got the opportunity to do that if I wanted to. And I think stepping back into clinics as well. So that's something I miss. So I used to do a lot of TB clinics, especially at GOSH. And also I did my prescribing in TB as well. So I was really fortunate to sit in with an amazing consultant back at Northampton and do the TB clinics. And I was able to go on sort of home visits and really get involved with these patients. So I think working in that setting where you're meeting these patients one-to-one is something I like to explore a bit more. Potentially getting involved in all of the global health stuff that Claire's been working on. So hopefully there'll be an opportunity to get involved with that as well. And I think just constantly looking at development and if there's any research opportunities and just really showcasing your work. So again, at Great Ormond Street, I was really fortunate that you're exposed to so much. And we managed to submit a few abstracts. And I was lucky enough to go to ECMID, which is like an international conference in Barcelona that happened this year, and present our poster. So that was an amazing opportunity. But I think pursuing that further, so really keeping in touch with all of these novel therapies and sort of keeping in touch with research and continuing with abstract writing and having the opportunity to attend these conferences as well, I think that's definitely something I'd be looking forward to.
Stepping outside your comfort zone.
Yeah, definitely.
What was it like stepping onto a stage to speak?
So thank God it wasn't a stage. It was just where your poster was displayed with all of the other applicants. But I guess just our poster was very interactive in the sense it had a lot of pictures, so it was attracting a lot of attention. And a lot of people wanted to come up to you and speak to you. And there was people from all over. So from many, like loads of different countries. There was doctors, pharmacists, lab technicians, anyone working basically in micro or ID was attending this conference, and just sort of meeting people from all over and getting to know them. And some of them, a lot quite sort of senior people, very sort of established in their careers. I guess it was quite daunting to be talking through my poster and being like, oh my God, like you're so well established. Like, why are you even taking the time and why do you want to look at this poster? But it was really encouraging as well, I think. And you're right, it was stepping out of my comfort zone a lot, going and just speaking to so many different people. But it was great with networking. And I think we had an amazing UK representation from AMS pharmacists this year at ECMID. So hopefully it does continue in the upcoming years.
100% agree. And I think it's really valuable to showcase that actually when we do different types of work as pharmacists, some of these conferences are really valuable to expand that network, but also it's a community. And what I've seen so far with those pharmacists who love antimicrobials, there is an amazing community and everyone's there to kind of support each other. They've got WhatsApp groups, you've got the UK CPA, and a lot of people are connecting together in order to help each other on the journey. And attending those conferences and being part of it, especially if you've got a poster or you're doing a presentation, really helps to get your passion flowing. It helps you to build more confidence, but also be part of that community, which is really valuable as pharmacists too. I really want to thank you for stepping out your comfort zone today. I know, like, being on video and talking about your story and feeling like you're imposter syndrome, sometimes it exists, right? You're like, what would people want to hear from me? But you've shared so much about your journey, obstacles that you've overcome, how to step up in terms of pharmacy. So I'm really grateful that we've had this conversation today. And, thanks so much for your time as well.
That's great. No, thanks for the opportunity, Anisha. It's great. Thanks.